I'm pleased to give the floor to Professor Surya from Mumbai, and the presentation will be about the organizational aspect, opportunity, problem, and policy for telerehabilitation in India. Please.
Thank you, Chairperson. At the offset, thank you, Professor Pablo, to having us here. I have with me my past president, Asian Indian Society of Neurorehab, Dr. Namjo. And I represent quite a few of organizations in India and Asia. And that brings to me to think about how to develop neurorehabilitation in India. As a matter of fact, the neurorehabilitation was not a priority at all in India for many years. It is for last 8 years that we have been able to bring this into a forum. So when you think about a neurorehabilitation as a specialty, it's not been considered as one of the specialty. How do we develop teleneurorehabilitation? So that's the biggest challenge, which I am going to give you some of my experiences and these are some of the newspaper cuttings, and you could see that how many doctors does India have? That's a very big question. And India to lead the mobile users, so there will be 1 billion by next year, and out of the world expected to be 5.5, so 20% would be only in India alone. And then you should see that 2024, India is going to be the #1 populous country, and you have 90 lakh beds for elderly by 2027 against 9,700 now. So all these lead us that we need to do something to develop teleneurorehabilitation in our country. I'm going to into the details, and then why teleneurorehabilitation in India, or that matter of fact, many of the developing countries. So if you see that 53% of deaths are due to the NCD, 44% disability adjusted for life year due to NCDs, 8% death due to neurological conditions, and 25% due to neurological condition of daily. And these are some of the problems. And if you see that, so I'm going to give you the 7 or 10 problems why the telerehabilitation should be considered. So that was one. Second is less number of neurologists in India. So I, being a treasurer of Indian Academy of Neurology, and get the request from neurologists to become member, by today I only have 1,800 full life member in India, which is such a big country, which is second populous country in India. And if you look at the required per doctor per person, and you could see that even at present position, it is 1.2 million per doctor. So we need to really do that. And then third problem is there are less number of rehab professionals. We don't have count of how many people are there in India. And if you see this WHO report from the showing about the need to scale up rehabilitation for physical and PMR, for the therapists, for the occupational therapists, and for the prosthetists, or you can see that there are hardly experts available. And what was in India is that people get trained, whether it's physio, OT, or speech therapists, they immediately leave the country in few years to abroad, and then most of them don't come back. So there is a brain drain from India, and therefore it is a real problem. Then fourth is non-availability of professional neurorehabilitation service in rural part. So we have a very big treatment gap. There are top-of-the-line centers like Abhishek has in Mumbai, but then there are no physiotherapists even in the rural area. Only the quacks and osteopaths are someone who does the exercises or treat the patients with severe injuries, whether it is traumatic brain injury or spinal cord injury. So again, we really need to consider how we are going to deal with lack of professionals. And then there is a burden on family and caregivers, because there is a mobility, cost of traveling to the centers or to the city or to the bigger center, a feasibility of visiting a center, and poverty, illiteracy, myths, and insurance. These are some of the problems, because India, the insurance is not covered. Last year, Mr. Modi, our Prime Minister, I'm sure you must have heard his name, he has launched the Ayushman Bharat And this is an insurance policy which is going to deal with below poverty line in India. And so I hope that Ayushman Bharat could include the neurorehabilitation and telerehabilitation in a big way. Maybe we need to work hard for the lobbying to the ministers. And then the sixth point is number of smartphones in India. I think we are smart in having the smartphone, and you could see that there is users will double by 2022. There is an average mobile data consumption in 2017 will increase to the 2022, and then there are online video consumption in India is rising. So people are getting technical savvy, and more number of people are using the mobile. So that's something interesting. And then there are technology advancements which are happening in India. There is an increased availability of services, and then meet the need of increasing independence and compliance. And lastly, there is a motivational and flexible scheduling of the patient therapy session, which would encourage that people will use more and more of telerehabilitation. So I've given you these 10 points which let me understand that India could use telerehabilitation because of these things. What are the various subfields of telerehabilitation which we still are using in India? There's a teleconsultation, tele-multimodal care, telehealth care, tele-home-based care, and tele-technology-aided rehabilitation. And what is the Indian scenario? So there is an initiation by Government of India, the National Digit Health Authority of India, which is in the process of being set up and has been clearly defined an action item in the National Health Policy 2017. So that's one positive thing. And the Ministry of Health and Family Welfare has already notified the standard to be used for exchange of health information. And this second edition of standard was notified in December 2016. So these are two positive aspects. Before I could come here, my friend showed me one of the order by the Bombay High Court of prosecuting one of the doctor under Section 304 for prescribing the treatment on the mobile phone online, and patient died. So she has warned me that I should not talk anything nonsense here. So what is the DigiGav initiative by Government of India? The Digi is digital and Gav is village. The village Hindi name is Gav. So DigiGav is India, and this will be launched, which provides provision of telemedicine, education, and skill using of digital technology, and aim to double the income of farmers by 2022. And there is a Pradhan Mantri Gram Digital Ayojana, which is extended to 6 crore rural households to accomplish the mission. So DigiGav is something which is happening. Yesterday we talked about digital home by somebody, and I think in Gujarat, which is the Mr. Modi's hometown, the first DigiGav will be happening this year. So budget 2018-19 health, as I mentioned to you, Ayushman Bharat, which is National Health Protection Scheme, and it provides coverage up to 5 lakh rupees per family for secondary and tertiary care hospitalization. And now, unfortunately, it still doesn't include neurorehabilitation and telerehabilitation. So we really need to lobby to the government to get onto this. However, there is a national rural telemedicine network, which is existing already at level 4. And all the various public health center, the primary health center, community health center are connected with district hospital in term with the major hospital across the country. And these are some of the programs which are already running: teleradiology, teleclinic for nuclear medicine, teleophthalmology, teleclinic for rheumatology, etc., etc. So they are already existing. And what is most interesting is Government of India has developed telemedicine at temples, because bigger temples, these are Char Dham, which are 4 places to go for. Everybody wants to go there because these are holy place, and at times there are millions of people going to the temple. So they have set up the doctors there, clinic there, and the patient can be seen there by a resident, and that is linked to the major hospital to guide the thing. So this is something which is free of cost, available in India through the government. But what are the advantages we have? Accessible to the patient in remote location, more acceptable and affordable, reduce the budget, and expanded in the hospital care, rehabilitation in home environment, reduce the burden on the healthcare worker. Indian telemedicine program is getting matured, and indigenous technology system and process, so it is cost effective unlike other places. And Digital India mission has further strengthened the policy for adaptation of telemedicine in India health delivery system. So we really need to do. But what are the problem faced? Less access to internet by disabled. There's a difficulty in using the devices. India is a large country, over 1 billion population, diverse social and cultural background, federal nature of governance, where health is a state subject, are acting as impediments for rapid access. Because each state has their own health schemes, and they are not governed by the government of India. And therefore, it is something which is difficult. But what are the future scope? The current research is variable and limited. Feasibility of telerehab in different neurological condition has to be seen. Development of optional protocol intervention for a specific condition has to be made. A development of telerehab software through Skype or other has to be developed, and development of telerehabilitation application for patient has to be done. So it's a very big job for all of us. So Government of India initiations are further important. They have integrated health information platform with the exchange of health information in an interoperable manner, and Ministry of Healthcare has set up the National Telemedicine Portal. So that's something positive, and we would really look into it, that how we can infiltrate there to get into. So now let's work on the Maharashtra, where I've been involved, and I've been working with Government of Maharashtra, interim Government of India for last 8 years. And there we have telemedicine center in JJ Hospital and KEM Hospital, which are the biggest hospital. This is by government, and that's by BMC. There are 6 medical colleges which are connected. There are 23 district hospital and 39 sub-district rural hospital. So about 66 centers are connected. And I must tell you that I am fortunate that I am the only private doctor outside this setup who is connected with all these 66 centers right in my clinic to do the telemedicine. So what's our experience? We're working with on the epilepsy for last 8 years, since 2011. Epilepsy Foundation, I'm the founder, trustee, and chairman, with Government of India, National Health Mission, which is a public-private partnership initiation we started. So what we did, this was a paper which we presented in one of the World Congress, and epilepsy and neurodisability, a hidden devil. And I will tell you that how multidisciplinary things through the telemedicine rehabilitation could be implemented in a rural area during the camps. So this is the model which I have developed, where we work both Government of Maharashtra as well as Epilepsy Foundation. There's a team of 50 goes. And what is most important thing is there are 2 physios, 2 speech therapists, 2 occupational therapists, and 1 to 2 clinical psychologists, along with the social worker, are part of this team whenever we go to the rural camp. So mind you, my next camp is next Sunday at one of the area, 150 kilometers from Mumbai. So these are some of the camp picture, and therapists do treat there and then only. And this is what is the data we have today by 78 camps. So 79th is next Sunday. We have seen over 29,000 patients. EEG is done, counseling is done for more than 2,000, physio, OT, ST for nearly 2,000 to 3,000 patients has been seen during the camp out of the patients which are seen by the neurologists and referred with disability to these doctors. And this is what we started to train the physicians, pediatricians in the rural area through the government. And we did 1 year telemedicine course, so training the people who are going to provide the service. And we want to take this model further to train the therapists and other experts for neurorehabilitation in the next coming years. So this was done in 3 phases. This is the circular from Government of Maharashtra. This is done right from my clinic. The first phase was one-on-one, and the second phase was all were connected together, and this is what we did for epilepsy. So this is what my center is, and we are connected like that. Then we had, whenever we see the patients for follow-up, initially when I was not connected, we would go to the JJ hospital and do the follow-up of these patients on a weekly basis. Now I'm connected every Tuesday, so anybody, any center from 66 can connect to me on any of Tuesday and show me the patients and talk to me and take their opinion. They send me all the data online before, and that is how it has been done. So there has been some of the papers and research which we have done in last couple of years, couple of months when Paolo told me, so we followed it, how we can think of producing some good things. So epilepsy patients, what we started is, we started looking at feasibility and effective of multidisciplinary rehab team on neurodisability seen in epilepsy patient. And we also wanted to evaluate the burden of telerehabilitation on caregiver and patient with mild to moderate disability with a smartphone who visited the free camp in rural district of Maharashtra, not taking any rehabilitation, were recruited in this study. So those who have never had therapy. So these were some of the paper which we presented, and this is we did eligibility assessment, baseline assessment by neurophysiotherapists, occupational therapists, speech therapists, psychologists, goal information and intervention decided by multidisciplinary team, recording of intervention given to the patient by caregiver. Each intervention is tailor-made for each patient. Intervention to be given for 1 hour per day, 5 days a week, for 1 month under the supervision and with the aid of the caregiver. And we did outcome assessment by multidisciplinary team post 1 month and post 2 months, and outcome assessment by multidisciplinary post 3 months. So this is what we really did in past few months. These are some of the protocols which we followed. And we gave some of the exercises like strengthening, balance, bad mobility, self-care, cognitive activity, play therapy, sensory integration, and psychosocial rehabilitation. So we had 13 patients which were included in those particular camp, out of which 8 were male, and mean age was 16.1 year. And these were percentage of comorbidity associated with these patients with epilepsy. And these were the 1 month follow-up, which is a patient with home therapy. The complete were 50%, and the partial was 20%. 30%, and nil was 20%. So they have compliance was assessed. And also pre-Barthel index score to post-Barthel index score was assessed by these therapists, and it was post is 59.3. And the important thing came out is the caregiver burden, which everybody reported that they have more caregiver. The caregiver felt that their burden has increased compared to what it was before. FIM scale was 97.4 before and increased to 103. So these are some of the therapies they are giving in the camp. This is one of the therapists who's doing now PhD, lecturer, and she has been very actively involved. And at 1 month, she has done the telerehabilitation through the follow-up through the telecenter. So these are some of the discussion which shows that it can be useful. And I'll just show you a video which is done in one of the camp at Pune, if it can run for a few seconds. Yeah, so these are some of the, during the camp it is impossible because there are thousands patients come in the camp and then they're selected, but you know, we have a separate rooms where they work together, so 10 therapists working in one room, so they give caregiver interview. So they try to find out whatever deficiency patient has, how we can improve. Can you wear the clothes without assistant or shirt? Then the caregivers are trained there only. And mind you, all these times somebody makes the video for them to show them what exactly they are doing, looking at motor disabilities, incoordination, imbalance. So then the speech therapists, we have similar experience from them. They have been These are some of the group therapy which we do at the camps by the physios and by the speech therapy. And then these are some of the special schools children who comes. So their teacher been trained, and we have getting some encouraging results. We will have to make out a standard protocol and follow them for the future. And we also, this Pune team from has seen a lot of patients. They are coming regularly in some of the camp, and these are some of the data where they have seen out of 4,000 patients, they've seen about 298 patients, and these are some of the data which we have done. Unfortunately, many of these are not been able to follow. Some of the patient has been followed in the post camp, and we still want to work out how best we can have the regular follow-up of these patients. Because WhatsApp, we are not been able to get the video back from them to guide them. So we are now trying to make a mobile app where they can directly upload their video and then we can guide them. This is our clinical psychologist who has worked, and what she has done is she give the counseling and then record the COLI-10 and the stigma scale, teach them, talk to them, and then we follow them after 1 month. And what we have, we do COLI test pre-treatment. And we also, these are most of the important topic that comes out pre-treatment. And stigma scale is being recorded during the camp. And these are quality of life post-treatment. And these are the pre and post comparison. You could see there is a significant improvement in the quality of life. And the most important topic is most important. And 7 is, first is the most important, that energy improves. And the least important is 7. So, you know, the overall quality of life, they feel that it has been better than before. And even there is an improvement in the stigma scales. So overall quality of life in patients with epilepsy is poor. This is what we know. And comprehensive care and counseling can create a positive effect, even in the camp where you're just giving 20, 25 minutes or 30 minutes to each patient. And then what we are also have developed now another system that about how we are going to do the post-camp follow-up. And this is what we have started for last 6 months. So all the data what we are having in the camp are electronic recorded, and then there is incoming as well as outcome support. And these are the data which has been scanned during the camp. And we call the patient every month. So there are about 1,000 patients being called up. These are some of the data from last year, January to June. And we call up each patient as per their convenience. And this is the center which we have. From here, they call the patients, they talk to them. So there are dedicated people, nurses and psychologists who are working there. And these are some of the response. The patient send that, you know, I have got this problem or I'm taking this medicine. So we are yet not been following that. What we do is we guide them to go to the nearest hospital, and we call the hospital, civil surgeon, and tell them that this patient is coming, kindly do this, and then they talk to me and follow it up. So these are some of the things, other things which we have been doing. We have been always involving the annual conference and have tele lectures. So this was done in 2015 from Abu Dhabi, where we directly linked the session completely. And then 2017, we had President Professor Lee talking to us. And this is Namjo. He is also was part of the tele lecture in 2017. And this was Shabat Vasti. And this was just last month, but we have also had Professor Lee talking to all the people on stroke rehabilitation. And this is Professor Humberto from Italy, who delivered about neuromodulation to improve function in spinal cord injury. I think this software was very interesting because it can be much better and it can give you better understanding to the people. And this is Sabat Vasti, who spoke from Abu Dhabi. So feasibility and utility, there are not many reports from India about the telerehabilitation. And these are some of the papers which are just been reported in last couple of years, which tells that there's a feasibility study. And it seems that we need to work harder on this particular point. And what we did is, from our Italian counterpart, Matilda, Caterina, a group, and Professor Satin was also here yesterday evening I met. So we did a survey where, on the Google survey, which we did, a survey study, by the Indian Federation in association with Coma Research Center, Department of Scientific Director Foundation, IRCC, Istituto Neurologica, Sibesta, Milan, Italy. And this study was published last month in Journal of Indian Academy of Neurology, which is Annals of Indian Academy of Neurology, where patients with disorder of consciousness in India, which is a preliminary result from a pilot survey. And we yesterday spoke that we are going to do the part 2 of pilot survey about the rehabilitation facilities, and there's some certain 20 questions which we have done. So that's very fruitful, and we have been collaborating with each other. So to summarize, the neurorehabilitation is an unknown entity in India. And that's largely because neurorehabilitation is not known at various levels. Increased awareness of neurorehabilitation itself will lead to more utilization of telerehabilitation. Low-cost cellular data service gives an opportunity to make it an integral part of follow-up services. I just want to tell you that in India, you just need to pay $1.5 to get monthly unlimited data, 1 GB every day. So that's what is the cost in India, and we need to tag on that. And need to infiltrate it to a already existing government program which I've given you, and Epilepsy Foundation care and service model which could lead to other organizations to follow. That means whenever there is a rural camp on any neurological disorder, they can use this protocol to treat with physio, OT, ST, and can give the teleneuroRehabilitation. Future is digital in neurorehabilitation in developing country, and I think every developing country should start working how to deal with the increased number of problems along with less number of trained staff. Thank you very much.
Thank you very much for the comprehensive presentation. Very interesting, the different experience. So the discussion is open to the floor. Are there any question or suggestion? Or? Please.
Yes, Dr.
Congratulations. That's mind-boggling. I mean, to see how much work you've done. There are only 24 hours in a day. I mean, how do you manage to do all that? And so
all my friends work with me, so it's not only me. So there are so many. So, you know, in a camp, otherwise to get a neurologist appointment in Maharashtra, impossible. For my camp, there are 10 neurologists. So my next camp, all Nasik neurologists on that Sunday, they are only coming for the camp. They're not going anywhere.
And
that's the commitment.
And how do you manage to do follow-up on all these patients, given the billion population of India? And
so it's very difficult, and you know, I always get frustrated when I want to do something and there are not enough people. But slowly and surely, at least we are trying to get one people interested. And we built from 1 to 2, 2 to 5, 5 to 10, and that strategy has really worked. This is difficult, I know, but I started with one person doing this, and then add to 2, and then add to 5, then add to 10.
Okay, thank you.